It's a pleasure to be here, and thank you for being here. It's very interesting times, isn't it? Sorry if I get this. And coming up this morning on the train, a bit crowded, as I guess everybody found it, standing there with my hand up, holding on to the bar so I don't fall off or don't get squashed. And there's a rather attractive young lady in front of me. And obviously, we all look at middle-aged men, married, happily married, look at an attractive lady as you do. And we all got off at, both of us got off at London Bridge. And she said, "Here, this is for you." I said, "God, I must be lucky today." And then she walked away, and I opened it and said, "Your zipper is open." I thought, thank you. I went up and said thank you to her. I think you start appreciating good people, and since then I haven't caught a cold. But I think as the other thing that's happened, you start appreciating in the new NHS is, since the GP commissioning thing came out, was how much we appreciate good management and our good managers. We suddenly found the value of our PCT managers we work with and fighting tooth and nail as we speak to keep our good management with organizational memory with us. So the other bit that came up in Callum's and when he started introduction was the difference with the GP commissioning and what happened with fund holding and total purchasing pilots. The difference, I think the key difference we tend to forget is at that time, the GPs were working entirely as providers. They were working for their practice, maybe joined up together in TPPs, but they were working as providers. And the difference now is that we were working as commissioners for the population rather than our practice. That's a key difference. And we must remember that because people will try and confuse those right through, and lots of people work across boundaries with experience from one side. From acute trusts have become deputy chief execs or the chief executive of the NHS. They don't only think about the acute trust, they also think about the entire NHS. So I think that is doable. And there were some very good papers by Richard Lewis and King's Fund written a couple of years back on fund holding and beyond PBC by Nuffield Trust, which gives us some direction if we were looking ahead with clinically led commissioning, what it could do. So just that's by the by. But since the white paper has come out, there have been a number of levels on this whole spectrum. There have been people who say dismantle it, the very, let's call them the right wing, so just dismantle it and it'd be all run it as a market economy. Haven't you seen it, how well it's done in America? Yeah. And how well it's done in Germany? Really? And we all believe that and it'll be fine. And then the other saying is, why are you giving this all to these mavericks and just have top down, control it and it'll be fine? I think there's a wise path in the middle and I think we need to tread that carefully. There is, of course, what is going to happen between 2012 and 13, but to get, as David rightly said, and there's lots of things that concur completely with David, was that we have to start preparing now. And as commissioners, and some of us who are going for the Pathfinders, and by the way, the Pathfinder is a there'll be the SHAs and PCTs will be asked to say yes unless there's a very good reason to say no, which is different from the past. So a lot of people will be going on the Pathfinder route. So we will need to start sitting down with our FT trusts and other providers now if we have to start commissioning properly. But let's start with the patient. I was part of the group that was looking through the work up to the Constitution, the NHS Constitution, and part of the group that was looking at the patient experience. And what came out quite clearly was the patients literally saying, "I don't care how much you know, I want to know how much you care." Because we are a health service, we are a service. And the bit that was most important to the 200 odd people were there who were in groups and doing skits and all trying to produce what are the key things. That compassion was the biggest thing that the patient wanted. That people actually cared about who they were, what they came with, and treated them with compassion. And we tried to define compassion, but I won't go into that because it's a long story. Trust, respect, dignity, of course, but getting the basics right, that the notes of the patient were there, that the computers worked, the transport got them there, getting those every day, the hospitals were clean, the GP talked to them nicely, the receptionists, they didn't have to wait so long on the phone, the district nurse arrived on time, and the rest of it. Those are the basic things that we wanted to do right. And if we got those right, then we should go for excellence. Not go for world-class commissioning when we haven't got the basics right. And I think that was quite important. And as a commissioner, with the patient in the center and looking for pushy participative patients to tell me what I need to do well as a population, we need to look at those basics. What are those basics from the patient's point of view? Because that's who we're there to serve. And the role of the GP commissioning, or GP-led commissioning, is about total health management. It is not about what we commission from our practices or from the hospital. It is about the whole journey, from protecting good health to easing the passing, which is about end-of-life care. 25% of people are admitted in hospitals for end-of-life care when they shouldn't be there at all, which is bad for them, it's bad for the community, and it's immoral for us to do this. And the preventative side has always got lost because we spend so much time getting people sick and then treating them. So I think we need to do something different, and this is our opportunity to do it. But what we mustn't forget is the whole issue about health inequalities and cultural diversities. It is part of the white paper that we have to deliver against, because people get caught up in the provider sector, any willing provider, what we do with the FTs, what will we do with GPs who will commission with themselves. But the bits that we really forget are the people who with low or no voice, who are in great need and are left on the side. And people with cultural diversity wanting to use services and do not have access to it. So access is the biggest determinant, or access to health or opportunity to be healthy is the biggest determinant for health and well-being. And I was at a lecture with Chris Bentley on Monday, and which showed that when you look at the risk condition and psychosocial aspects of it, that directly lead up to behaviors that lead up to physiological risks. And if we don't do something on your left side of the graphs, the right side is going to come and hit us. And it's much more expensive, it takes much more time, and it's bad for the patient, and it's bad for the economy. But we know this, that nationally more people are living longer, but not always healthier. Lives and healthy gains are not evenly distributed. We know that, we can see it in the communities. When we look at where the health provision is, the best health provision is in the areas where the people are the healthiest. The poorer get the poorest public services. That law of inverse law is well known, and a lot of that is related to poverty and aging populations. But some people have done this. When you see the light and the dark colors come together, you know they've done well to reduce health inequalities, and other people haven't, like the one in the yellows. And so within your own communities, you've probably got you somewhere in that spectrum. And we know, if you don't do anything, just to labor the point which David is making, that in the last 10 years, the huge GDP in the US has doubled on health. And when you look further, by the end of the century, they could be spending half of their GDP on health if you didn't do anything different. And mainly, as they call it, to the seniors. So aging population, long-term conditions. 70% of all our health spend is spent on long-term conditions, and about law of 70s really, 70% of people who are admitted in hospital are with long-term conditions, and 70% of them are elderly. So we've got a perfect storm, and I'm not sure general practice commissioning is part of the storm or part of the boat. You can decide for yourself. But we know the credit crunch. We know what's happening everywhere else, and so we have to do something differently. If it was all about reorganization, in the last 20 years of my general practice, I've seen 7 reorganizations. We would have got the design right by now. So we've got to do something different. So it has to be more than reorganization that we've got to do. We've got to do something fundamental. And if the tsunami is coming, this is the worst posture we could take. And a lot of my colleagues are deliberately taking this posture and finding reasons to dig deeper, get the head in deeper. And I'm sure there are other parts of the system which are also doing exactly the same.